Thank you very much. It's a pleasure to be here, and it's also a distinct pleasure to be asked to chair this session. Unfortunately, Dr. Orr could not be here this morning. So it gives me tremendous pleasure to introduce our first speaker, who really needs no introduction. Dr. Richard Warner has been treating patients who have neuroendocrine tumors for more time than most of us have been around, and his experience is tremendously invaluable, and it's just so wonderful to have you come here all the way from Mount Sinai in New York. Thank you.
Thank you very much. Students, ladies and gentlemen, colleagues, guests, and anybody who fits into a category of others. My job is to give you a quick oversight of what's going to follow and to help make it meaningful for you. The theme of this conference, of course, is networks of expertise. Well, just what does that mean? Obviously, any disease is most efficiently and effectively managed if it's diagnosed and treated by experts in that particular illness. The family of neuroendocrine cancers, although it's progressing very slowly, has been doing so, and nonetheless, it's relatively rare that a doctor or a center encounters a patient with carcinoid or one of these other neuroendocrine tumors. And very few really have a great experience or are well-versed in the heterogeneous spectrum that these tumors, these disease groups present. They're varied. It's not a matter of you've seen one, you've seen them all, they're all the same. They're not. They're quite different. They only have a few common features. For example, here are a group of dogs, canines, all of them. But look how they differ. They're all of the same family, but they're all various different breeds. Similarly, all neuroendocrine tumors are of the same family, but they're all different kinds. And even within each kind, there are variations. No two carcinoids are really identical, and they vary considerably. Therefore, it takes a wide experience to be able to do the optimum in managing any given case. And this is part of the important concept that is necessary to understand why a network of expertise is so essential. Now, all of these tumors may look alike to begin with. They all stem from the same cell of origin, the enterochromaffin cell, which is sprinkled about in the body, unlike other endocrine cells which may be aggregated in one organ to a specific have a specific function. These cells are scattered. They can be in the gastrointestinal tract, where most of them are, in the pancreas, in the lung, and a few scattered in other diverse places. But nonetheless, this counts for a great variety in the way they present and the way they behave. And also, the cells may be very much like the cell from which they originated. In other words, they may look very similar, or they may vary a little, or they may vary tremendously. For example, here is a brick wall. All the bricks are the same. So if we can liken it to a tumor, we can say that this is a very well-differentiated tumor. Every single cell is the same as the cell from which they originated. Now here's a wall with bricks that vary considerably in their appearance. They're all about the same shape and size, but they vary in their coloration and so forth. So this could be called a moderately differentiated tumor. And now here's a stone wall in which there's tremendous variety. different color, different size, different shape. And so in the cells of a neuroendocrine tumor, if there's such a variation, so-called pleomorphic, then it would be a very poorly differentiated tumor. And this type of distinguishing feature helps to determine the aggressiveness of the tumor. This is a detail that has to be given considerable attention in evaluating biopsies. And this is another reason why no one tumor is the same as any other one, and it takes experience and expertise to really understand the most out of it. The ones that are poorly differentiated, tend to be much more malignant. Now, looking further microscopically at these tumors, we can see in the panel A, the upper left-hand corner, is a characteristic or so-called typical carcinoid. The cells have all pretty much the same feature. Looking down at C, where it says H and E, which stands for the stain, hematoxylin and eosin, which is a standard stain used for most biopsies, the cells are all staining pretty much the same. They're strands of fibrous connective tissue in between, but they're all pretty much the same. Then we start to look at other features, and I won't dwell on some because it's not pertinent to what we want to point out. However, look at panel D, and you see a couple of arrows, and they're pointing to spots where there are dark nuclei in the cells. These are areas or cells that are undergoing mitosis, and it's important for the pathologist in the biopsy to look at and see how many mitoses are going on and count how many in a given number of cells, the so-called mitosis index or count. That helps to give an idea as to the rapidity of growth of the tumors. And then we have other stains. In the upper right-hand side, we see the darkly brown stained cells. That's a stain for chromogranin A, which is characteristic for all neuroendocrine tumors. And there are other such things we can stain for called synaptophysin and so forth. These are features that help distinguish that that is the type of tumor we're dealing with. Not just carcinoid, but the other neuroendocrine tumors too. And then we can stain for something called Ki67. And you see a little arrow pointing to a dark spot, and that's a cell in which the Ki67 stain has been demonstrated, and that means that that cell is undergoing mitosis, is replicating. And look, next to it is another one where there are myriad such dots, and that means that this cell is rapidly growing. The more mitotic figures there are, as demonstrated by Ki67, the more rapid the cell is growing. All these are things that distinguish different tumors and their aggressiveness and have to be given attention and studied. Now, individual tumors can be distinguished also by what hormonal products they make. They don't all make the same thing. And yet, if we do the standard H&E stain, they'll all look alike. For example, if a tumor is making gastrin, then it's called a gastrinoma, and it has other symptoms than the average carcinoid. It may make serious ulcers, it may make diarrhea of its own type, and the only way we're going to know that that's a gastrinoma is if we stain and show that that tumor produces lots of gastrin. Of course, we may find it in the blood, too, as a chemical marker. So it's not good enough for the pathologist to just say neuroendocrine tumor, or, as often was said in the past, since they all look the same, they call everything carcinoid. That's no good. The treatment, the management, the prediction of the outcome, the course is all going to be different by differentiating the different specific type. And all these have to be done through special staining and other specialized tests. For example, we can have profound diarrhea being produced by a tumor that makes VIP, a so-called vipoma, and that requires a special stain and special blood tests. All this has to be gone into in a given case. And now, to go on, many tumors will present with the same symptoms, very common symptoms, symptoms that will be attributable to many, many usual diseases. And therefore, the average physician encountering a patient who complains of abdominal pain, well, they're not going to think of carcinoid right off the bat, or of gastrinoma, or any other type of neuroendocrine tumor. They're going to think of a common thing. Or in other words, when you hear hoofbeats, you think of the usual cause of hoofbeats. You think of horses. But we're now teaching everybody involved to start thinking at least of zebras too. The zebra is a rarer cause of hoofbeats, but would represent the carcinoid. So one has to think outside of the box, and this is what we're trying to do. Many of these tumors will have, because of the delay in diagnosis, will have spread extensively. In fact, between 13 and 50% of cases already have distant metastases when they're first diagnosed. And consequently, it's very important for the doctors to think of this possibility. It won't be there most of the time, but it'll never be diagnosed if it hasn't been thought of. And that's the hardest part in the diagnosis of these tumors. Well, anyway, here are some more of the common symptoms. Abdominal pain, yes, may be present for years. And then eventually intestinal obstruction, and I'm talking more of carcinoid now. Occasionally there'll be bleeding as the presenting symptom, because the tumor will ulcerate and cause bleeding. And this is not a common cause of gastrointestinal tract bleeding, so it's not thought of right away usually. And then eventually a mass may be present, or it may be the first thing that's found. And a patient goes for an annual exam and a lump in the belly is felt. Or even the patient may feel a lump himself and go to the doctor and say, "What's this lump I feel?" And then finally, features of the carcinoid syndrome, which only less than the majority of cases will have as their presenting symptom, maybe flushing or maybe profound ongoing diarrhea. Those may occur. So this is for gastrointestinal neuroendocrine tumor, the commonest of which is carcinoid. But for lung carcinoids, which accounts for some 28% of all carcinoids, we may have it as an accidental finding. This also occurs with carcinoid. For example, an X-ray is taken for some other purpose, maybe a routine chest X-ray before the patient's going to have a gallbladder surgery, or maybe some other simpler surgery, and a lesion is seen, a shadow in the lung, and then it's further explored and turns out to be carcinoid. This is not an unusual way of a lung carcinoid presenting. Or a patient may have recurrent infections, pneumonias, always in the same place because of the growth in the bronchial tree of a tumor, which deters proper drainage of that portion of the lung. And so a regular chest X-ray may show only an infiltrate. They've got to do a CT scan. The doctor has to be wise enough to think to look further. Maybe coughing with bringing up a bit of blood, hemoptysis, that can be the first presentation. Or the first presentation may again be a mass in the abdomen or a lymph node. It's already metastasized. And then a syndrome, a carcinoid syndrome from the lung, from a lung carcinoid, or lung carcinoids can produce a variety of other syndromes because they have the ability to make many different types of hormones. So we may have Cushing's syndrome, for example, or syndromes of almost any variety, because just about every peptide hormone that has been known has been found one time or another to be produced from a lung carcinoid. So we have a wide variety, a wide range of things that can happen or that can be the presentation, and it takes some expertise to be familiar with this or to think about it. Now, here we have the patient in the center. The patient is the center of all this interest. And look at the wide variety, the wide number of specialists that may be involved, most of which have to be involved in every case. We may have the generalist, or internist, or family doctor is the first one to whom the patient may go with some complaint, or even for a routine exam. And that is the person that the patient usually relates to the most. We may require endoscopy, or patient may be seen by a gastroenterologist because of diarrhea, or maybe we have to do an endoscopic ultrasound study looking at the pancreas because of a tiny lesion being seen on a CT scan in the pancreas. The radiologist is very much involved because of all the different types of imaging studies that are necessary, and we need a radiologist of experience. And it's very easy to miss small things or to mislabel them. One of the commonest errors is to see a small lesion in the liver and have it called hemangioma, when it really isn't. It's metastatic neuroendocrine tumor. There are many such instances, and it's not really proper to just brush it off and say that's what it is, because again, it's hearing hoofbeats and calling it horses. You've got to think of the other possibilities and do appropriate tests for that. The pulmonologist may be called upon to investigate pulmonary symptoms, whether it be coughing up blood or seeing a spot on an x-ray. So we may need a bronchoscopy or some other sort of involvement. The medical oncologist, of course, is one of the keystones in the management, but that depends upon the details of how he's been helped by all these other specialists. A surgeon may be needed, and here it's not enough to just take it out, and that is the only way at this point in time in our management of these diseases that we can effect a complete cure, is to be able to totally excise the original tumor, and if there's already some regional spread, take that out too. Otherwise, what we can do is only palliation or prolonging survival, but that's worthwhile too. And of course, we need the oncologist for that. The pathologist is essential, as I've indicated to you. So these are some of the specialists that are needed, and here we have more. The radiation oncologist, we have the nuclear medicine specialist, and now especially with the development of peptide receptor radiotherapy, we have other modalities of treatment for eradicating or at least regressing tumors. And we also have various diagnostic means, the Octrio scan, for example, and coming up, gallium scan. Then we have the interventional radiologist for doing catheterization procedures and injecting materials into the liver, whether it be chemotherapy or emboli or radioisotope-bearing particles. And this has a distinct role, which is growing currently in treating these diseases. We have the cardiologist because of the frequency with which heart valve lesions occur in carcinoid. We have the endocrinologist because of all of the various hormonal syndromes that may occur. Many patients get to the endocrinologist first. And then we have some inheritable forms of these diseases, so the genetic expert is essential. And many patients need rehabilitation, physiotherapy, nutritional assistance, and the involvement of a nurse practitioner. So we have many, many experts in many, many fields that are germane to the best care of patients with these various tumors. And it is obviously not possible for any one physician solely to manage one of these cases because of this wide variety of problems. We need a group, whether it be a group of individual doctors aggregated together as experts or all concentrated in one center. We need that. We need, therefore, a network of expertise. And this entire conference is devoted to elaboration of all these many facets of these neuroendocrine tumors that I've touched upon and the roles of the different experts that we've discussed. So herein following will be all of these details, and you will learn more. Thank you.
Thank you so much, Dr. Warner, for an excellent overview and introduction.